Imagine you just you take a blunt pen and you draw it really firmly down your forearm. Within seconds, you get this white line. Then it turns red. Then, the skin actually physically swells up.
Yeah, you've basically just triggered this microscopic, highly choreographed alarm system that evolved, well, millions of years ago.
Exactly. And if you are sitting down to take your MRCS exam, knowing the exact physiological timeline of those first few seconds and the chemical mediators driving them is literally the difference between a pass and a fail. So welcome to the deep dive.
Right, and this is a rapid-fire, high-yield revision session hosted by two surgeons specifically designed for you, the surgical resident preparing for the MRCS. We are translating those macroscopic clinical signs you see in A&E directly into the microscopic cellular drivers you just have to memorize.
Yeah, no fluff today.
Mhm.
But before we unpack the cellular battlefield, here is a highly targeted public service announcement for your exam prep. Head over to medsynclimited.com/Anki to get the MRCS Accelerator ANKI deck.
Oh, that dick is a lifesaver.
It really is. I mean, it contains over 2,400 questions across 23 themes, including 15 subspecialty topics. And it's designed specifically to help you recall those commonly tested facts. Get it, use it, pass the exam. Now, no waste of time. Today's topic is inflammation.
And we're going to use a direct question and explanation style here to cover everything from the acute vascular phases all the way to those highly testable granulomatous giant cells.
Let's start with the big picture, right? When we're looking at tissue on the ward. What is the fundamental textbook difference between acute and chronic inflammation?
Well, what's fascinating here is that it basically just comes down to timeline and function.
Yeah.
I mean, acute inflammation is the initial, often transient reaction to an injury.
Like the body's immediate first responder.
Exactly. Throwing everything it has at the wall to contain the damage. Whereas chronic inflammation is the subsequent, usually prolonged tissue reaction that just takes over if that initial response fails to clear the threat. They are completely different cellular landscapes.
Right, so when a patient rolls into the emergency department with this hot swollen abscess, we are looking at the macroscopic signs of that acute first responder phase.
The classic 5 signs, yeah.
Yeah, we all learn them: rubor, calor, tumor, dolor, and functio lesa. But the exam doesn't just ask for the Latin, it asks for the underlying physiology. So let's break those down. Redness or rubor, what is physically happening to the vessels there?
Rubor is simply due to small vessel dilatation. The microvasculature opens up to allow way more blood into the area. And that directly ties into the second sign, heat or calor.
Because of the blood flow, right?
Right, because you have increased local blood flow, and since that blood is coming from the core of the body, it physically warms the skin.
Which brings us to swelling or tumor. Now, this isn't just blood pooling, is it? We are talking about fluid actually leaving the closed loop of the vascular system.
That is the critical distinction. Tumor is driven by edema. The permeability of those dilated microvessels increases, which allows protein-rich fluid to leak out of the intravascular space and straight into the extravascular tissue.
Now, pain or dolor, my instinct is to just think of this as raw nerve irritation from the injury itself, but it's more complex than that, right? Is it the physical swelling causing the pain, or is it chemical?
It's actually a combination of both. There's absolutely a mechanical component. The physical stretching and distortion of the tissues by that edema. I mean, think of the excruciating throbbing pressure of pus trapped in a closed space like a perineal abscess.
Oh, brutal.
But there's a massive chemical component too. Mediators like prostaglandins and bradykinin are actively stimulating those local nerve endings.
Which perfectly explains the final sign, loss of function or functio lesa. It just hurts too much to move, so you get this conscious and reflex inhibition of the muscle. Plus, the physical swelling kind of acts like a biological splint, immobilizing the tissue.
Precisely. The macroscopic presentation is just a shadow of the vascular changes happening underneath.
Okay, let's unpack this. I want to look closer at that vascular phase because there is this classic historical observation that always shows up in the MCQs. Lewis's 1927 triple response to injury.
Oh, a classic.
Yeah, this goes back to my example of drawing a blunt instrument across your skin. The tissue doesn't just instantly turn red and swell up. There's a really specific 3-step timeline: flush, flare, and wheal. But I want to know what happens at second 0, like right when the instrument strikes the skin.
So the very first thing that happens, even before the flush, is a transient white line directly along the track of the blunt instrument. This is an immediate arteriolar vasoconstriction.
So the vessels clamp down.
Yeah, it's a rapid protective reflex spasm of the smooth muscle in the arterioles to prevent any potential bleeding. But
Yeah.
It really only lasts a few seconds.
Wait, if the arterioles are clamping down, how are we getting all that extra blood flow for the redness?
Because the local chemical mediators immediately override that reflex spasm. The white line disappears and is replaced by the flush.
Okay, the flush.
Yeah, the flush is this dull red line exactly where the instrument tracked, and it's caused strictly by local capillary dilatation.
So the capillaries open up to receive blood,
Right.
but then the redness spreads out, right? You get this wide, irregular red zone around the track, which is the flare. If the capillaries cause the flush, what causes the flare?
The flare is caused by arteriolar dilatation. The arterioles upstream of the capillary bed just open wide, completely flooding the entire local network with blood.
Which is a massive pressure spike.
Huge. And that sudden massive increase in hydrostatic pressure leads us to the final stage, the wheal.
The physical raised bump.
Exactly. The wheal is a localized zone of edema. Because the capillary hydrostatic pressure has skyrocketed and the vessel walls have become more permeable, protein-rich fluid exudate is literally forced out into the extravascular space. Way more fluid is leaving the vessels than returning to them via the lymphatics.
Okay, so we've talked about how fluid and proteins leak out to form that physical swelling. But fluid alone doesn't clear an infection. The body needs boots on the ground, the white blood cells. How do they actually escape that fast-flowing vascular highway to reach the tissue? Break down this exudative cellular phase for us.
Right, the journey of a neutrophil from the bloodstream into the tissue is this highly choreographed 5-step sequence. Step 1 is margination.
Because they're usually in the center of the vessel, right?
Yeah, normally red and white blood cells flow down the central, fastest-moving axis of the blood vessel. But as the vessel dilates and blood flow slows down during inflammation, the neutrophils fall out of that central stream. They move to the periphery and start rolling along the endothelial lining.
But they can't just roll forever. I mean, they have to stop. Step 2 is adhesion, and I know this isn't just random friction. The endothelium is actively trapping them.
It is a highly specific lock-and-key interaction. It involves paired adhesion molecules on both the surface of the leukocyte and the surface of the endothelium. Think of it like throwing a tennis ball at a wall versus throwing a Velcro ball at a Velcro wall.
Right.
During inflammation, the expression of these Velcro adhesion molecules is rapidly upregulated.
So what's the trigger? What is telling the endothelium to put out the spike strips?
Chemical mediators. Specifically, complement protein C5a, leukotriene B4, tumor necrosis factor, and interleukin-1.
Okay, so they roll to the edge, they stick firmly to the wall, then they have to actually get out. Step 3 is migration.
Yes. The neutrophils actually squeeze through the junctions between the endothelial cells. They do this actively, using amoeboid movement, literally pulling themselves into the extravascular space.
Now, step 4 is diapetesis, and I feel like this is a massive trap for exam candidates, because it sounds like it should apply to the neutrophils, but it doesn't, does it?
It definitely does not. Diapetesis refers specifically to the escape of red blood cells from the capillaries. And unlike the active crawling amoeboid movement of the neutrophils, diapetesis is entirely passive.
They just get pushed.
Yeah, the red cells are simply forced out through those widened endothelial gaps by the sheer force of hydrostatic pressure. They're basically squeezed out like toothpaste.
That is such a crucial distinction. Neutrophil migration is active, red cell diapetesis is passive. Finally, step 5 is chemotaxis. Once the neutrophils are outside, they don't wander aimlessly. They follow a chemical scent trail straight to the site of injury. So what are the main drivers of that chemotactic gradient?
The most potent chemotactic factors for neutrophils are interleukin-8 and, once again, leukotriene B4. They act like a homing beacon.
I want to pause on those chemical drivers for a second because the chemical mediators are where candidates start losing marks. Let's talk about the complement system. It feels like an absolute alphabet soup when you are revising.
Oh, absolutely.
You mentioned C5a putting up the adhesion molecules earlier. Break down the high-yield complement proteins. We need to know exactly how they function, not just what they're called.
Well, the complement system is a cascade of 20 proteins synthesized in the liver and macrophages. They circulate in an inactive form until triggered. Let's look at the heavy hitters. You absolutely must know C5a. It is highly chemotactic for neutrophils, it increases vascular permeability, and it triggers mast cells to release histamine.
Okay, so C5a is the master alarm. What about C3a?
C3a does the exact same things as C5a.
Yeah.
Chemotaxis, permeability, histamine release, but it's much less active. It's kind of the weaker cousin.
Understood. Now, what about the cytolytic ones, the ones that actually destroy the bacteria directly?
That is the membrane attack complex, made up of complement proteins, C5, 6, 7, 8, and 9. They don't just poison the bacteria, they physically assemble into a cylinder and punch a microscopic hole straight through the bacteria's cell membrane.
And it just bursts.
Literally, fluid rushes in and the bacteria explodes. Note that C5, 6, and 7 on their own, before the complex is fully formed, are also chemotactic for neutrophils.
So C5a and C3a sound the alarm. C5 through 9 act as a specialized demolition crew punching holes. Finally, what about C4b, 2a, and 3b?
Their job is opsonization. Trying to phagocytose a smooth, slippery bacteria is really difficult for a macrophage. So C4b, 2a, and 3b coat the surface of the bacteria.
Like giving it handles.
Exactly. They act like molecular handles. Once the bacteria is coated or opsonized, phagocytosis is massively accelerated.
They just serve the bacteria up on a platter. Now, aside from complement, there are 3 other key mediators we need to nail down: histamine, prostaglandins, and bradykafekin. Let's run through how they actually alter the environment.
Sure. Histamine comes mainly from mast cells, basophils, and platelets. Its primary action is to cause immediate transient vasodilatation and increase vascular permeability by forcing the endothelial cells to contract, which widens the gaps between them.
Right, and prostaglandins are next. I mean, we give NSAIDs to block these, but what are they actually doing physiologically in the tissue?
Prostaglandins, which are produced by cells like platelets and macrophages, basically potentiate that increase in vascular permeability. They keep the vessels leaky, but they are also deeply involved in the regulation of platelet aggregation and disaggregation, managing local clotting at the injury site.
And bradykinin. If a patient is screaming in pain, bradykinin is usually the culprit. But it isn't just floating around freely waiting to be triggered, is it?
No, it's locked away within the kinin system, which is a plasma protein cascade. Bradykinin increases vascular permeability, but it is primarily a chemical mediator of pain. And what you must remember for the exam is the exact master switch that generates it.
Which is?
Coagulation factor 12, also known as Hagman factor.
This is where it all connects. Factor 12 gets activated by exposed basement membranes or bacterial enzymes. And once it activates, it kicks off the coagulation cascade, the fibrinolytic cascade, and the kinin cascade all at once.
It's exactly right. Factor 12 converts prekallikrein to kallikrein, and kallikrein then cleaves kinogen to release active bradykinin. It is a massive, coordinated, physiological alarm bell.
So what does this all mean? The alarm rang, the flush, flare, and wheel happened, the neutrophils migrated, the complement punched holes. What does all this microscopic warfare look like to us on the ward? What are the actual macroscopic sequelae of acute inflammation?
There are really 4 potential outcomes here: resolution, separation, organization, and progression to chronic inflammation. Resolution is obviously the ideal scenario, complete restoration of tissues to normal.
But resolution only happens if the conditions are perfect, right? Minimal tissue damage, rapid destruction of the bacteria, rapid clearance of debris, and the organ actually has to have the capacity to regenerate, like the liver.
Yeah, and if any of that fails, we are called in.
Let's talk about separation then.
Separation is the formation of pus, and pus is a highly specific mixture. It contains living, dead, and dying bacteria packed together with exhausted neutrophils, cellular debris, and liquefied necrotic tissue. It's usually driven by persistent pyogenic bacteria like Staph aureus, Staph pyogenes, coliforms, or Neisseria.
And when this pus accumulates inside solid tissue, it forms an abscess, but it doesn't just spread infinitely. The body walls it off.
Right, it creates a pyogenic membrane. This membrane surrounds the abscess cavity and is composed of newly formed capillaries, neutrophils, and occasional fibroblasts trying to contain the damage.
Which leads directly to a classic OSCE question. Why, physiologically, must surgeons incise and drain an abscess? Why can't we just put the patient on strong IV antibiotics and wait for it to clear?
Because antibiotics travel through the bloodstream. Inside the abscess cavity, that liquefied necrotic center has 0 blood supply. Furthermore, the pyogenic membrane acts as a physical barrier.
So the drugs just can't get in.
The bacteria are physically inaccessible to both systemic antibiotics and your own circulating antibodies. You cannot clear an infection if the drugs cannot reach the target. You have to physically open the space and evacuate the pus.
The ultimate surgical maxim, let the pus out. Now, what about organization? This is another sequel that causes endless surgical headaches.
Organization occurs when the damaged tissue is replaced by granulation tissue. This happens when there's a massive volume of necrotic tissue that simply can't be cleared, or when there is an excess of fibrin formation that just swamps the body's fibrinolytic system.
So instead of dissolving the fibrin clot, the body just builds over it.
Yes. Capillaries grow into the inflammatory exudate, and fibroblasts proliferate wildly under the influence of transforming growth factor beta, or TGF-beta. These fibroblasts lay down collagen, which results in dense fibrosis.
Which is a brilliant mechanism if you were trying to heal a deep skin wound, but an absolute nightmare inside the abdomen. Give us the classic surgical example of organization.
Peritonitis. The bowel becomes inflamed, and a sticky, fibrinous exudate coats the loops of intestine. They stick together to try and wall off the infection.
And if it doesn't dissolve?
If the body's fibrinolytic system fails to dissolve that temporary glue, organization begins. TGF-beta drives fibroblasts to invade the fibrin, they lay down collagen, and that temporary sticky exudate becomes a permanent, tough, fibrous adhesion binding the bowel loops together. This is a fundamental cause of mechanical small bowel obstruction years down the line.
We also need to mention the systemic effects of this acute phase. When a patient is fighting off an infection, we look for objective markers. What is happening systemically?
Systemically, you will see pyrexia, weight loss, and constitutional symptoms like malaise and anorexia. Hematologically, you'll find a leukocytosis, a massive spike in white blood cells. You'll also see an increased erythrocyte sedimentation rate, or ESR.
Just to clarify, the ESR mechanism that happens because inflammatory proteins like fibrinogen coat the red blood cells, making them heavier so they fall faster in a test tube, right?
Precisely. They stack together like coins, a process called rouleau formation. You might also see reactive hyperplasia resulting in swollen lymph nodes or splenomegaly. And anemia is common, either from blood loss into exudates, hemolysis from bacterial toxins, or the anemia of chronic disease caused by bone marrow depression.
And there's one specific severe systemic complication regarding long-standing inflammation that examiners just love to test.
Secondary or reactive amyloidosis. During chronic inflammation, the liver constantly pumps out serum amyloid A protein. Over years, this protein can misfold into beta-pleated sheets and deposit in organs like the kidneys and spleen.
Like in TB or rheumatoid arthritis?
Exactly. You will see this tested in the context of long-standing conditions like tuberculosis, rheumatoid arthritis, or bronchiectasis.
Which is the perfect pivot to our final major topic. We've covered resolution, suppuration, and organization. But if the causative agent isn't removed, acute inflammation progresses to chronic inflammation. What does that cellular shift look like under the microscope?
Well, the term chronic indicates a complete overhaul of the cellular infiltrate. In acute inflammation, neutrophil polymorphs are the dominant cell. But as it becomes chronic, the short-lived polymorphs die off and are replaced. Lymphocytes, plasma cells, and macrophages basically take over. The tissue structurally organizes around these mononuclear cells.
Here's where it gets really interesting. This brings us to granulomatous disease, a highly specific type of chronic inflammation. The MRCS exam is obsessed with granulomas. First, just define a granuloma based purely on the pathology text.
A granuloma is an aggregate of epithelioid histiocytes.
And what exactly is an epithelioid histiocyte?
It is a macrophage that is transformed. It flattens out to vaguely resemble an epithelial cell. When these transformed macrophages cluster together to form a granuloma, they actually lose a lot of their phagocytic activity. But importantly for your exams, they become secretory.
They secrete ACE, right?
Yes. They produce angiotensin-converting enzyme, which is exactly why ACE levels are elevated in granulomatous conditions like sarcoidosis.
Right. And sometimes there is caseous necrosis in the center of these granulomas, which is the classic hallmark of tuberculosis. But where you can pick up incredibly easy marks is with the giant cells. These histiocytes can fuse together to form multinucleate giant cells, and they have distinct visual features based on what they are fighting. Let's run through the lineup and explain why they look the way they do. First up, Langerhans giant cells.
Langerhans cells are classically seen in tuberculosis. The defining feature is a horseshoe arrangement of peripheral nuclei at one pole of the cell.
Like they're corralling it.
Exactly. The macrophages fuse and carefully organize their nuclei to the edge, trying to contain the mycobacterium within a structured boundary.
Next one, foreign body giant cells.
These just look chaotic. The nuclei in a foreign body giant cell are randomly scattered all throughout the cytoplasm. This happens when macrophages encounter something completely indigestible, like a piece of surgical suture, talc, or uric acid crystals. They try to eat it, fail, get frustrated, and just fuse haphazardly to surround it, resulting in a disorganized scattering of nuclei.
Number 3, Toten giant cells.
Toten cells have a distinct ring of central nuclei, but the key differentiator is that they have clear peripheral cytoplasm that is swollen with accumulated lipid. You see these at sites of adipose tissue breakdown and in xanthomas. They literally gorge themselves on fat until their periphery is totally clear and lipid-filled.
And finally, histiocytic giant cells.
These form to permanently wall off particulate matter that is chemically inert but completely indigestible, like inhaled silica.
So the organized horseshoe for TB, the frustrated random scattering for foreign bodies, the clear lipid periphery for fat-eating Tootin cells, and the inert histiocytic cells for silica.
If we connect this to the bigger picture, it all comes down to patient communication. Let's look at a classic OSCE scenario, scenario 16.3. Imagine you are in A&E. An 8-year-old girl is brought in after falling and banging her arm. The arm is pink, hot and swollen. The child is happy, vital signs are normal, and the X-ray confirms there is absolutely no fracture. But her mother is highly anxious. She says, "I don't understand why her arm is red, hot, and swollen if it isn't broken. Does she need antibiotics?"
That is the ultimate test of basic sciences. The mother is looking at rubor, calor, tumor, and dolor, and basically equating them directly to a microbial infection.
Yes. And your job in that OSCE station is to explain that inflammation is a normal, localized physiological response to physical trauma. You have to explain that the blunt force of the fall caused a triple response: flush, flare, and wheal, leading to capillary dilation and fluid exudate, which causes the swelling.
So it's sterile.
Exactly. It is a sterile physical injury driving the inflammation, not biogenic bacteria. Therefore, antibiotics will do absolutely nothing except expose the child to unnecessary side effects.
It is entirely about using your deep knowledge of vascular phases and hydrostatic pressure to confidently reassure a patient. Now, as you take this knowledge back to the wards and into your revision, we have one more targeted recommendation for you. Head to medsynclimited.com to get their surgical simulation kit.
Those INS kits are brilliant.
Yeah, it includes a suturing kit, microsurgery instruments, and more. Because understanding the theory is only half the battle, the physical muscle memory is what actually makes you a surgeon.
The theory guides the hand, but the hand must be trained.
So true. If you found this rapid-fire physiological breakdown helpful for your MRCS prep, press follow on the show so you don't miss our upcoming deep dives into other highly testable subspecialties. And if you learned something today, take a second to rate the show.
We also really want to hear directly from you. Leave a comment or a question about the material we covered today. What is the one physiological cascade that always trips you up?
As you close your books today, think back to that 8-year-old in the A&E. How would you adjust your explanation of local vascular control if the mother asked you why the swelling happens so fast but takes days to go down? Just ponder how the immediate physics of hydrostatic pressure driving the fluid out contrasts with the slow, methodical pace of lymphatic drainage clearing it away. Keep questioning the why behind the what. We'll see you on the next deep dive.